It is 12:05 on a rainy Saturday. It's a good day to grab a phone, give us a call. Dr. Payne shows here. Dr. Payne, every time I talk about this show, it's like I think you're a Bond character, but that's not the case. Luigi Nally is here. He's Dr. Lou. He's a doctor dedicated to pain management, taking your phone calls like we did last week. Anything under the umbrella of pain management. We're talking physio. We're talking anything to help the body. Let's talk a little bit again for those who are new to the show exactly what the purpose of this whole thing is, right?
Yeah. Thanks, John. I guess the same thing that we've discussed over the last few weeks is really we want to try to demystify pain. Pain is something that's often poorly understood in healthcare, even though it's so common. We tend to understand so much more about things that seem more complicated, like if we're talking about cancer or heart disease. These systems seem like they'd be much more complex. But having said that, there's such a psychological component and such a social component and such a physical component with pain that there's a lot that's really poorly misunderstood and poorly managed in healthcare. Oftentimes, what happens with pain is a lot of times people will go into their doctors, whoever they're seeing, and their pain gets dismissed because they've been there so many times. I was thinking about a story as I was coming here, and this happened a few months ago, actually, where a patient was referred to me for neck pain, and the physician had sent that patient to see me for this neck pain and had taken x-rays and just sent it off to me and said, "This is a patient with simple mechanical neck pain. Can you help him out?" Obviously, the key to what we have to do is our thorough assessment. So when I was looking at this patient and I was talking to them, this was a middle-aged man, but otherwise very healthy besides that. No other confounding issues that were going on. And as I was going through his assessment, he had nothing that really stuck out to me, no red flags. We finished the history, then we went on to our assessment. As soon as I touched his neck, his lymph nodes were just swollen everywhere.
You could feel it just,
just instantly. And that was one component that was missing that the family physician forgot to do was let's feel this person's neck, see what's going on. And all these lymph nodes were just swollen, all kinds. And so at that point, that's when the flags started going off in my head. And it basically became, this is something more than just simple mechanical neck pain. Sent him back to his family doctor, who I have a very good relationship with. We ran all the necessary tests. The patient ended up having lymphoma. What he thought was simple mechanical pain ended up being something that was very serious, but thankfully was caught early, and I believe he's okay.
See, it's amazing. You'd expect, not that you'd expect that he did anything wrong, but his doctor, with the white coat in the office, you figure if he's going to find anything, he's going to be the guy. But it was that opinion on the other side.
Yeah,
that helped,
and
right?
You know what? The family doctor called me right after and said, "Thank you so much." And you know what? The thing is, sometimes you just get busy, and it could happen to anyone. It's not necessarily negligence. It's just a simple mistake. And you know what? He was thankful to have me in his toolbox of other providers to use. And that's where you build the relationships with other providers. You build it with people that you know that you could trust, that if you make a mistake on that day, someone else may have your back. And that's the key with what I've done is with the team that I've built. I want to make sure that there's someone there that's always there to catch a backup plan.
416-870-6400, star 640 on cell. We are taking your calls throughout this hour. You have questions about pain management, stuff you've been through. We'd love to hear your stories and your questions if you're looking for answers. That's kind of the way you set up your entire practice. You're not just focusing on one thing. You have a pain management team, right?
That's right, yeah. And we've talked about this in the last few weeks, that really when it comes to pain, and as I alluded to earlier today, is that it's so multifactorial that you therefore need a team of different kinds of professionals to deal with that, all the way from, the mental aspect where it would be a psychologist or psychiatrist, to the social aspect, working with social workers, all the way to the physical aspect, the rehabilitation, sometimes medication, sometimes surgery. You really have to have a team in place where you look at what the patient needs, and then you could put that together to serve the patient.
Do you find pain medications usually I'll say the first frontier that people come with you? They're already on the T3s or they're on the pain medication to start with because they haven't found the source yet, right?
Of course. And just by the very nature, as humans, from an evolutionary standpoint, we want to conserve energy, and the easiest thing to do is take pain medication. So it's often the first thing that we can go to. It's easiest for us. It's going to conserve the most amount of energy. Doing anything else might require more energy. So it is something that people will often default to. And again, sometimes it's absolutely necessary, and sometimes it needs to be necessary throughout the course of treatment.
I should remind you as well, if you're new to the show, we do this every Saturday at noon here, and Dr. Lou's Number, by the way, 1-855-55 Dr. Lou. That's DRLOU. Not that I had to spell it for you, but that's the case. We're going to take a quick break, get into the meat of this. You want your phone calls coming up. The phone lines are wide open, just getting rolling here. Dr. Payne Show on Talk Radio, AM 640. That is right. It is 12:14. Lines are wide open. You got a question for Dr. Lou? You in pain? Healthcare matters. We can handle them all. I want to get into this, guys, before we go any further. Now, Dr. Lou, we have not really a guest. He's here every week. He's just really quiet. Anthony's in the studio. He's your brother, right?
He is my brother.
It's a family show. Brother. Now, radio is the thing we love. We love radio. That's what I've been doing for years. But the news is there's a TV show coming up.
We do love radio, but we also love TV.
Look at you guys hitting the TV. What else? It's unstoppable. Give some details.
Well, I'm a television producer. Mm-hmm. I've got a show called The Aviators. It's going into its 7th season. It's been on Discovery Channel. It's on PBS. It airs around the world to tens of millions of people around the world. And we thought, what's the next subject that we can target here? Mm-hmm. If there only was an interesting character that we could do something with and share some good information. And didn't Dr. Lou just present himself?
How about that? So it's going to be, you're going to be getting a TV show happening in early 2017?
It's going to be in 2017. Okay. TV's a little slower to kick off than radio, but I think radio is a great way to build up Luigi's persona and get him out there in the general public, and then put him on TV and share a lot of the same information that we're doing, but create a visual component as well, and just have some fun with it. It's not going to be a dry, slow-moving show. It's going to be. Right. We're going to have a lot of fun with it, a lot of entertainment, a lot of interesting information, a lot of cool visuals. One of the things that we want to do is go to some of these big, intimidating machines that people are afraid of, diagnostic tools.
And the tunnel, right?
Yeah,
the MRI tunnel.
Yeah, and let's dispel some of those myths of what makes them terrifying,
Scary.
And let's go.
Right.
They're not going to hurt you. They're well, I mean, maybe I'll go in it. Maybe Dr. Lou will go in it. Someone's going to go in it, and you'll find, hey, it's just something. It's a tool that does what it does. It doesn't hurt. It's not intimidating, and it's a good thing. And this is the kind of stuff that we're going to show on the TV.
So that's coming in 2017. You go to facebook.com/Dr. Lou TV. Check out more for updates there as well, right?
That's right. Yep.
And for the purpose of this hour, 416-870-6400 *640 on cell. Peter in Oshawa. Good afternoon, Peter. How are you, pal?
Okay. I just wanted to ask you, I had diagnosed about a week ago, and then I had it for about a week before that. Real hot, humid days. I've been working on job sites, and I had blisters, like a blister rash at the side of my leg, and there's maybe a 2 inch by 2 inch, and then up further the leg there was another 2 inch by 2 inch, and then all the way up to the side of my waist, basically on one side. I went to a walk-in, and he said, I think it's just a fungal rash or a heat rash. He gave me some cream, and it had 1% of cortisone on it. And basically, the rash just kind of disappeared, but I noticed a burning sensation still down my leg.
Mm-hmm.
And also my back's been hurting, my muscles been hurting, never before, and I've been sleeping more, and I go, seems like more than a rash.
Yeah, Peter, which leg is this on?
It's on my left side.
On the left side, on the inside of the leg, and it's tracking from the inside of the leg up towards your hip area and into your back, is that right?
It hasn't gone into my back, really.
Okay,
It stopped right up my waist,
mm-hmm.
and then my back, and then my back left side that the same thing is on has been killing me.
Okay. And there's a pain component to this where there's pain going down the leg?
A bit, yeah.
Yeah. My next question is
the burning sensation,
mm-hmm.
I got a sunburn.
Yeah, and
that whole area.
I don't know if you know, but the rash, when you looked at it, did it kind of look like little pimples that were fluid filled that were clear?
It kind of looked like little blisters.
Yeah. So something like that actually sounds like shingles more than anything else. And that's how shingles usually presents. And that type of virus resides in what's called the dorsal root ganglion of the spine. So oftentimes what'll happen is it follows the nerve path. And what you're describing is what we would call a dermatomal path, which is the path of sensation for the leg. So if it's not better yet, the best advice I have for you right now, based on what you're telling me here on the radio is that it does sound like it could be shingles, and I would go get that checked, because if it is, you're going to need some type of an antiviral like a cyclivar. And the dangerous thing with shingles is not really while it's active and present. It's something called post-herpetic neuralgia, which is that the nerve tends to learn the pain and can reside there for a long time. So that's usually what happens to be a little bit bigger of an issue. So if it's something that's still going on, I think your best bet is go get that checked out right away. And it sounds like it could be shingles.
Yeah, it does. When he looked at it, he goes, "No, it's not shingles. It would all be one. It would all be one patch."
Yeah, and you know what? Sometimes what we talk about is something called prodromal or early. So sometimes the symptoms that we know that are textbook don't necessarily present on day one and may develop. So when you went, what was it, a few days ago, may not have been textbook, but all of a sudden now today it may be a little bit more textbook.
Right.
His cream that he given me, basically, it's dried up the rash.
Yeah.
Well,
Well,
it
for
really stop the pain.
No, and it won't. A cortisone cream, any type of hydrocortisone cream, it's a steroid-based cream. So it's just really meant to help heal the rash if it's a rash not due to something like shingles. But with shingles, that's a virus, and it's not about anything that you're going to do exactly to the rash. It's more about applying an antiviral to that.
You mentioned the nerve thing there in that discussion. I want to come back after the break and ask you what it meant. In the meantime, 416-870-6400, star 640 on cell. See, that's why we're taking your phone calls. Dr. Lou is here. He's answering them. Give us a call. Lines are open. Dr. Payne, Talk Radio, AM 640. 12:23, Dr. Payne show is here till 1 o'clock with Dr. Lou. You know that time, the big joke is you walk into a party, you meet someone's doctor. Yeah, doctor, I got this pain. This is the time you can actually do that and call through. That's the whole point of the show. So give us a call, 416-870-6400, star 640 on cell. Before we move on to another call, you mentioned some nerve. What is it again?
Post-herpetic neuralgia.
You said something about the nerve learning the pain?
Yeah, so what happens with the herpes family of viruses? So we were just talking to, I believe it was Peter, our previous guest, and we were talking about shingles, and that's herpes zoster, which is the same thing as chickenpox. It presents later in life. It's also the same type of virus that exists with cold sores. It's part of the herpes family, and what happens with this virus is it basically lives in your nerve at what's called the dorsal root ganglion, which is kind of the processing center for the sensation component of your nerves. And so that's why something like a cold sore gets reactivated, because that virus actually stays there. And when there's some type of a trauma, it can reactivate. And so the same thing happens with shingles when that happens, that if the pain is there for long enough, that sensation becomes learned and that pain can stay in that area of the body.
It'll linger there because now it knows it.
Yeah. And we've dealt with a lot of patients with post-herpetic neuralgia, and it's a very, very tough thing to get rid of because it's learned. And once it's learned, we talked about this on day one. Once you learn how to ride a bike, it's really hard to forget to
unlearn it.
Yeah.
Right.
It's often harder to unlearn than it is to learn.
416-870-6400, star 640 on cell. Dave in Belleville. Pardon me. Hi, Dave. How are you?
Good.
Okay. You got a question for Dr. Lou? Go ahead.
Yeah, my doctor said I had a vitamin B deficiency, and it had to do with absorption, and come every month for a vitamin B shot.
Vitamin B or vitamin D?
I think it's a B.
Yeah, vitamin B. Yeah, that's what I was going to say. Was on the computer here, I see vitamin D, but that's not nearly as common as a B12 deficiency. If you have a deficiency and there's no way for your body to absorb it, the only option that you do really have is to go get those injections every few weeks when the doctor recommends.
Okay, and what's that from? Is it like something I can eat different, or is it just how it is?
Yeah, if it's a deficiency where the doctor's recommending that you need to get injections, it's likely not due to a deficiency in your diet. It's likely due to a deficiency in your body's ability to actually absorb the nutrient. So you're probably doing the right things to get the nutrient, just your body's unable to process it. And in that case, that's where you need to have those injections. And one of the things with vitamin B is oftentimes, and with a vitamin B deficiency that contributes to the pain syndrome, is neurological type of pain. So I'm not really sure about your history, but is there any type of history of nerve type pains like sciatica and things like that?
Yes, I do have sciatic.
Go.
Yes.
Yeah, and a lot of times it's important when you're dealing with those pains, you may think it's just physical by, a tight muscle or a herniated disc. It could actually be, like in your case, where it's a vitamin B12 deficiency. So, yeah, I think if the doctor's recommended injections, it's likely due to a deficiency of malabsorption.
Okay, thank you very much.
No problem.
So are they doing that because the absorption, they have to bypass the digestive system to get
That's
the
right.
vitamin B? They got to go right to the bloodstream,
They got to go right into it, yeah.
No kidding.
Yeah.
Wow. That's pretty fascinating stuff. And I'm going to get to an email that came in here. If I can read this with my fantastic eyes. Don't work on eyes, do you? William
know
says,
people that do.
Right, I bet you do. William writes in, says, spontaneous pneumothorax in 2008. I've run a full spectrum of regular traditional treatments with no success. Went to a pain doctor who just wanted to push pills, although some could be helpful. I still do not think I have found one that is nearly effective enough. Nerve pain by the T7 after removal of a tube which had become attached inside. That's when I began pain, rib pain, back pain, stomach pain. Any recommendations for managing this type of pain?
Yeah, that's another loaded question with something like a spontaneous pneumothorax, which is extremely rare to happen. But this is kind of similar to a lot of times women with pregnancy with an epidural. Once something goes into an area of the body, like some type of an injection, if it's kind of in the wrong part of the spine that you're injecting into, it can leave these long-lasting pains. I think for something like that, I'd have to know more to really divulge what maybe he's done or what he hasn't done and what he's already done, and maybe go from there and give him some closer pointers on exactly what he could do to get something like that better. But really, a question like that, you really need to know a lot more information in terms of what exactly was done just after.
Right.
Because a lot of times that's what matters, is what was immediately done following that trauma. And that even goes for people when they're on their own and they hurt themselves. If they don't do the right thing right away, that's oftentimes the start of a chronic pain cascade.
Yeah, it can exacerbate from there,
That's
right?
right, yeah.
Yeah, that number, William, if you want to call Dr. Lou, 1-855-55-Dr. Lou. We'll get in a quick call here before a break. Carlos in Toronto. Good afternoon, Carlos.
Oh, hey, thanks for taking my call.
No worries.
So my question's really quick. I got rotator cuff issues in both my left and my right shoulders, and I also have calcific tendonitis in my right shoulder, and it's quite painful. I'm wondering if there's anything apart from the physiotherapy and pain medication that I could do to help either minimize or get rid of the pain completely. And I can take my answer off the air. Thanks.
Thanks, Carlos.
Yeah, so we had a question last week, actually, that went back to shoulders. And really, we were discussing about the shoulders and how complicated they are. And a lot of times the presentations of a tendonitis or a rotator cuff pathology really presents because of the function of the shoulder. When you look at the shoulder's connected to the shoulder blade or the scapula, and that scapula has to sit on the rib cage. And if it's not sitting on the rib cage the right way by having strong muscles, it will make various degree changes in the shoulder that put added stress on certain soft tissue structures. So a lot of times with these shoulder injuries, it's not really about the tendonitis or the bursitis or the pathology. It's actually more about, let's look at the function. And if we can determine the proper angles to be doing things at and find a way to get that scapula sitting properly on the rib cage again, then that's usually the magic bullet in that type of treatment.
Because as we said last week, going into a break here, I'll just touch on this, that the shoulder is a very unique joint. It's a weird joint.
Yeah,
right?
it's in my opinion, the hardest joint to treat because of how mobile it is and how its inherent structure. It's not a good architectural piece like the elbow or the knee, where if you took away all the soft tissue, they fit together like a puzzle piece.
Right.
The shoulder doesn't really do that. It actually just kind of hangs there besides the soft tissue that's holding it in place.
We'll take a quick break. Love it. More of your phone calls coming up. If you want to give us a call, we got lines open, 416-870-6400, star 640 on cell. Dr. Payne Show continues on Talk Radio, AM 640. 1232, Dr. Payne Show. Dr. Lou is here, 1-855-55. Dr. Lou is your number directly, and you know the number for the radio station taking your call. Should mention as well, 100 Humber College Boulevard. That's where your clinic is,
That's
right?
the flagship clinic, yeah, but we do have a network of providers across the GTA for those potential patients out there that can't get there. And, we just to mention again, like you did at the beginning of the show, people can add me to their Facebook page, and it's Dr. Lou, Dr.LOU. And there's a lot of neat stuff on there. We post, we post a lot of these things that we're talking about on there. People can also find out a little bit about me and my hobbies and the things I like to do. I'm just a normal person.
There's a normal guy.
Normal guy.
Got Phil in Toronto. Good afternoon, Phil. What's your story?
Hey, how you doing? Yeah, after spending the whole day yesterday in emergency, after ultrasounds and CAT scans, they diagnosed me with pancreatitis.
Mm-hmm.
Now, they're talking about enzymes coming out that you release from your pancreas. Mine was at 250. I didn't really understand the doctor's talk, but they said normal numbers are 50. Make a long story short, pain subsided last night, and it's starting to act up again today. But I'm just wondering, there was no painkillers given, and they say the main cause of this is excessive alcohol, but I'm not a drinker. So, I'm just a little concerned about, could it be an ongoing thing for me?
Yeah, something like pancreatitis, which is inflammation of the pancreas, it's just a general symptom. A lot of times people will go into a hospital and they're told that they have a symptom. It'd be the equivalent if you went in and you had a fever and you left and they told you that you have a fever. Oftentimes with pancreatitis, there's some type of underlying issue going on. Okay. And yes, it can become inflamed with excessive drinking, but like Phil's mentioning here, he's not a drinker. So there may be something else going on that's causing that type of inflammation. And although the pain is something that's bothering you right now, they really, even if they gave you painkillers, if they don't get to the root cause, there's not going to be really much that those painkillers will do. Right. So I would say that the best thing that you should do is follow up with your family doctor and figure out why is your pancreas inflamed. Because if you're not a drinker and there's no good reason for it to acutely flare up like that, well, then we should try to get to the bottom of why it would.
Right. Okay. Because I've been taking Tylenol for the last 3 days, and it helps a bit, but again, I
know you're throwing it back like Tic Tacs and not doing anything, right?
Yeah, it's tough, right? If it's not targeting the area, and there's probably a component of you that's also worried, the psychological component, and you could take the strongest pain medication, but your mind's going to be stronger. And if you're worried about it and you're anxious about it, that's going to diminish the effect of that medication. So I think the just based on the concern that I'm hearing your number one priority is get that anxiety under control in terms of go to someone who can help you figure out exactly what's causing that pancreatitis.
416-870-6400, star 640 on cell. Got lines open. Joe up in a really good afternoon, Joe. Hey,
Good
Joe.
Afternoon.
Hey,
Good
there
afternoon. Sorry, hi.
No worries. What's up?
Hi. I've been diagnosed with 2 osteophytes in my cervical spine that is pressing on my nerve going down my right arm. Now, in the last year, I haven't been in a lot of pain, but my doctor says that as they continue to grow, that may become a serious issue, and at that point, I would need a fusion of my spine. Resolve the issue. And I'm wondering, is there anything that can be done? Is there any alternatives to fusion, number one? And number two, is there anything I can do between now and then to either make it not happen or extend the time?
Yeah. How old are you, Joe?
I'm 47.
47. So that's still relatively young. And then for our viewers who don't know what an osteophyte is when bone starts to become arthritic in the neck and it starts to grow bigger than it should. It becomes what's called an osteophyte. And a lot of the times with osteophytes, and we had a caller talk about this with stenosis last week, those osteophytes will occlude the areas where the nerve or the spinal cord comes out, and that's what causes the pain syndrome. And yeah, there are some things that can be done for sure. And, I would say give us a call at 1-855-55-Dr. so that we can help you get you to someone who can do things other than just the fusion. The problem with fusion surgeries is that you can fuse a segment, but then what ends up happening above and below is problems start to occur there because you've now removed an area of movement.
It's got to go somewhere else,
It's
right?
got to go somewhere else.
Yeah.
So oftentimes fusion is good for removing that initial pain that you're feeling from that, but it often leads to a constellation of other symptoms in other areas.
Right. How's that sound, Joe?
Well, that sounds interesting. It's. I'm wondering if there's anything I can do to prevent those things from growing more.
Yeah, there are going to be things, and this is where it comes down to function and the types of things you're doing day to day, where you need that thorough assessment for someone to really look at you, take into consideration everything that you're doing in your day, and make the recommendations on how you can change your function in order to slow the progression of those osteophytes, because nothing is going to make it disappear at this point, right? They're there, and the only thing that can happen is you're either going to slow them down if you do the right things, or you're going to do the wrong things, and it's going to expedite it and probably lead to more serious neurological symptoms.
Again, Joe, that number 1-855-55 Dr. Lou. Mohammed will get you in here before the break. What's going on with you? Hi, Mohammed. Mohammed. I hear a beeping noise. That's never a good sign. We'll put Mohammed on hold for a sec. Is it Jalen?
Yes, it is.
Hi, Jalen. What's going on?
Well, I had to do this beep test at school and gym. So you run for 10 seconds, and then it's like 20 meters.
I remember it, yeah. I remember the beep test.
So I got a cramp, and then ever since then, it was like a week ago, like yesterday, and I get cramps every single time I walk, even like at home in my kitchen if I get up.
Where is the cramp?
In the side, in my waist. Like, you know, when you jog and you get a cramp, it's there in the side.
So one of the biggest, there's a muscle called the psoas, which is actually the filet mignon. It's the same muscle as the steak. It's a hip flexor, and it attaches from your lumbar spine down into your hip, and it's what causes your hip to flex. And a lot of times these cramps are actually due to that muscle being overused and something that you often don't do, like a beep test, and that muscle stays in a chronic contraction. So the key with something like that is oftentimes finding someone who can actually assess the psoas properly, and if it needs to be released in terms of doing some soft tissue work, release it. And oftentimes it's kind of a magic cure.
So like a massage therapist or something like that?
Yeah, any type of the physical type of therapist will help with that, whether it's a chiro or a massage therapist. The biggest thing is finding someone who's competent in assessing the psoas, because it's not an easy muscle to get to, and it's a muscle that's often avoided.
Can you do that stuff?
Absolutely.
You know the people, right?
Yeah, of course. And I see that she's in Woodbridge, so that's not far from our flagship clinic, so give us a call.
Jalen, that number 1-855-55 Dr. Lou. We're taking a short break. Phone lines are open. You want to call the radio station, you know that number by now, 870-6400, star 640 on cell. Dr. Payne continues. Talk Radio, AM 640. Got phone lines ready for you at 12:44 here. Show is flying by. We'll try Mohammed again. Hi, Mohammed.
Hi, hello, Doc.
There you are.
Yeah.
What's going on? What's your concern?
I am listening to the show, and somebody described me as a T before. I have burning sensation and a feel bruised and sore on my right side, just above the hip.
Mm-hmm.
And then a week now, it broke out to be a rash.
Right.
I went to my doctor, and he said I have shingle.
Yep.
And he gave me some medication.
Mm-hmm.
I could tell you the medication name. I have it in front of me. VALACYCLOVIR.
Okay.
And they have a APO in front. I have to take 6 tablets per day.
Yep.
For 7 days.
Okay.
Now, I forget to ask him if shingles is contagious. I didn't hear you talk about that in the show.
Interesting question.
It's really more contagious for anybody who has never had chickenpox. So if you've had chickenpox, it's not really.
Why is that?
Just because you've never been introduced to the virus. So a lot
similar.
of times, anytime a virus, and that's what a vaccine is, right? It's a weakened form of a virus introduced for your own body to build an immune tolerance to this type of virus. So it's the same type of thing. It's oftentimes, if you've had chickenpox, you're usually in the clear. But having said that, that's not an absolute rule. That's why now they're starting to introduce the shingles vaccine, and that's something that will make it less likely that, and even that won't guarantee that you won't contract it.
Yeah, so if I want to move around, I go to function and meeting and this and that. So I shouldn't be going because I can pass it on to somebody who had chickenpox before.
Yeah, it's a kind of a tough question. I would definitely, if it's also, you kind of have to touch the vesicles and get the fluid out of the vesicles and then touch yourself in order to be contagious. So if you're going to a meeting, they're likely not going to just be rubbing your shoulder for no reason on its skin. So it's not like you're going to breathe on them and that's contagious.
Right.
But as long as I would obviously make sure that no one's actually touching the rash, unless it's a healthcare professional. But I mean, I've seen patients with shingles and I've, didn't have gloves on and I've kind of poked around to see and it's fine, right? But there is the the chance that, yeah, it's absolutely contagious. And I wouldn't advise that anybody take that type. Even I should be wearing gloves. But, I remember the one time I just didn't have them readily available.
Appreciate the call, Mohammed. Enjoy your lunch. Kevin in Toronto, how are you, pal?
Yeah, not too bad. How you doing?
Good. What's up?
Basically, I got soccer injury about a month ago playing, and it was some discomfort in the bottom of my foot, and they diagnosed it as plantar fasciitis.
Oh, that's nasty.
Now, as I was playing, I noticed some discomfort, and then I had to stop playing at some point because it was becoming very hard to run.
Mm-hmm.
And then the next day, I couldn't walk at all.
Okay.
And then a couple days after, I was slowly able to put a little more weight on it, I am seeing a physio right now, but I'm just wondering, I have no confidence in it to be able to run. I'm just wondering, how long, or is there anything else I can do to kind of speed up the healing process?
Yeah, my first question would be, is it actually plantar fasciitis? Because oftentimes, some type of instant trauma doesn't really cause something like plantar fasciitis. If it is plantar fasciitis, fine. The difficult thing with any foot issue is that if you had a shoulder issue, you had some type of an acute injury, oftentimes we would just tell you, try to minimize your use of it. Mm-hmm. The problem with any foot injury is in order to minimize the use of the foot, you'd have to stop walking, which obviously we're not going to advise.
Or hop around on one foot.
Yeah, and that's the dangerous part is with foot issues, they do tend to take a longer time to heal just because of the very nature that you need your feet to move around.
Right.
Yeah.
Yeah. So, I think it's worth a discussion to be had with whoever's working on it. Is it something that's painful first thing in the morning for you, or if you?
That's usually the most painful, and then I have to drive for work. So whenever I'm in an hour or two in the car without anything, and I start walking again, I'll have a little bit of pain, and then it will kind of subside, or maybe I've just gotten used to it.
And the thing with people with plantar fasciitis, the thing that I recommend the most is anytime you've gone through a period of rest, like throughout the night, or you're sitting in a car, all the things that you're describing, the reason why the initial impact hurts so much is your foot naturally has a springing sensation to it. So once you've been sleeping and it's staying in its nice curved position for 8 hours, it tends to heal that way. And then you introduce gravity and all your weight to it, and boom, it kind of rips. It's kind of like if you had a cut on your knuckle and you kept bending, you slept all night, and then you woke up in the morning and you just, bent your finger right away, it would start bleeding again. So the biggest thing with that is warm that foot up. So before you get up in the morning, before your big first step, start moving that foot around, massage it a little, move it around, get it warm, going back to our conversation about warming up, getting those enzymes
versus
going.
Stretching,
and getting it warmed up so that initial impact isn't as aggressive as it would be if you hadn't done that.
Is there any sort of appliance they give you or wear for plantar fasciitis?
There are some simple things that you could do with plantar fasciitis. Sometimes what people recommend to keep a really good arch in your foot is you take a really big sock and you kind of pin the front to the ankle. It really depends. I don't know that I really buy the fact of putting it into more of an arch, just because then when you take your initial step, then there's more springing happening. So it's just a tough thing to treat. I do recommend to people to kind of break up that scar tissue, to roll their foot on a golf ball before bed, stuff like that. So that's something that he could try.
We'll take a quick break. 416-870-6400 star 640 on cell and outside of show hours or any time for that matter. Dr. Lou's number, keep it on you. It's 1-855-55. Dr. Lou. It is Dr. Payne. The show right here on Talk Radio, AM 640. 12:52. We'll get to as many as we can here over the next few minutes, right till 1 o'clock. 870-6400 star 640 on cell. We'll get to Ruth. Hi, Ruth. Good afternoon.
Hi. How are you?
Good. What's your question for Dr. Lou?
Well, I was just telling the lovely young lady that does your screening. I met a friend today that I hadn't seen for quite some time, and of course we exchanged pleasantries and, cheek to cheek and patting and whatever. And then during the conversation, I said to him, "What have you done to your eye?" He says he had herpes simplex something or other. Mm-hmm. Is that contagious? Should I be worried about this?
How long ago was this contact?
An hour.
An hour ago? Yeah, yes. I think the best recommendation is I wouldn't worry. It's going to be very rare for something like that to be contagious. And, if you do start seeing any signs and symptoms, the dangerous part is if you think about signs and symptoms, you often start to develop or think that you have those signs and symptoms. So my best advice for you would be just don't worry about it. You likely are fine. If for whatever reason you do start noticing stuff, you're going to have to take the proper steps to get it looked at. But I highly doubt that you contracted it.
Oh, thank you.
Okay.
What are the symptoms?
For something like that, for ocular herpes? Different types of vision type of issues, pain in that area of the body. Again, the dangerous thing is if I start telling you all these symptoms, you're going to start feeling
That's
them.
That's what I've got.
And, you're going to be driving around thinking that you have herpes in your eyes, but you don't have herpes in your eyes.
Already.
Don't worry about it.
You're fine, Ruth. Got Walter. Good afternoon, Walter. Thank you for calling in.
Thank you. I've been in the hospital for 7 months. I just got into rehab with a bunch of hospital-inflicted ailments, and one of them, the worst one, is a really bad bed sore on my coccyx, which is taking forever to heal.
Yep.
I've been on a vac dressing, which they've taken off. I'm just wondering, in terms of pain management, they're giving me hydromorphone, which I don't want to get addicted to, and they've been giving me up to 9 Tylenols a day, which I refuse to take just because of the recent Health Canada warning about taking too much Tylenol. So I'm wondering if there's any other safer alternative short of going to a higher pain medication.
Yeah, the thing with bed sores, it's really tough. Anytime an area of the body, and it's often common with bed sores in hospitals that that area, the sacrum or the coccyx, will undergo necrosis, and that's what a bed sore is. It's necrosis, which just means cell death in that area. And so, like Walter alluded to, they'll remove the area that's died, and then they'll do something to pack it and help regenerate the tissue. The harder part about that is the areas in that part of the body that were initially feeling pain that kept sending that signal back and forth to the brain, and now all of a sudden there's that pain pathway that's been developed. It's a tough question to answer specifically on exactly what can be done with the conversation over the phone. I'm happy to speak with you a little bit more privately to hear a little bit about it. So if you like, after we're done the radio segment, if you give us a call at the 1-855-55 Dr. Lou, I'll speak to you personally and see if there's anything that we could do to recommend to help you.
Good, thank you. Well, the wound's been healing nicely because I'm using a carbon 60, which is a ultra-high antioxidant from Europe for free radical scavenging.
Right.
I just wanted to look at the pain management.
Yeah, for sure. And I think that's, an area that we're going to be able to play a better role in terms of the advice. And I'm happy to hear that the wound is healing well, because a lot of times they don't, but that's great that it is.
Walter, appreciate the call. Get to Alex here in Toronto. Good afternoon, Alex. Go ahead.
Yes, good afternoon. So I've been feeling this symptom for a couple of years now, actually. Probably more like a few years. It's my right foot. It kind of happens throughout the day, where I feel like it's pins, like pins or needles, going at the sole of my foot.
Okay.
And to this day, I still haven't been able to get a clear answer from my doctor on what this could be from.
Yeah, there's so many things. The one thing I could tell you for sure is that pins and needles is a neurological type of symptom. So obviously it's something related to the nerve. Now, what the next step becomes is what's wrong with the nerve? Is it something that's central nervous system, like in the brain or in the spinal cord, causing that type of tingling? Is it something in the back, like a disc herniation, that's putting pressure and you're feeling it at that end of the nerve? Or is it, something peripherally, a tight muscle in the calf that's causing that? Or even sometimes things like diabetes cause peripheral neuropathies and can have sensations like that. So there's so many different things that could lead to a pins and needles sensation in the bottom of the foot. And I'm not really sure who you've had look at it or not look at it and what they've said could or could not be the cause.
Okay, well, I haven't been to any chiropractors. It was just my family doctor that I've been to.
And what did the family doctor say? This is obviously a chronic issue that's been going on for years. And, the harder part is when something is chronic, it's going to be much harder to treat if there hasn't been much done in terms of that. But I think the key becomes trying to figure out exactly, it's a symptom, right? We know it's a neurological symptom. Now we have to figure out at which point in the body is that nerve being affected and treat the cause of that.
So I mean, what specialist would I would I have to go see in order to get some answers on
I mean,
this?
I'm going to be biased and say give us a call at the 1-855-555 Dr. Lou number, and we can get you to one of our providers that I know personally will be able to definitely assess pins and needles types of sensation and give you a clearer answer for sure.
Busy day today. We'll wrap it for another week. Mandy, hang on the line. I know Dr. Lou wants to get to you after the show. In the meantime, till next week, the number is 1-855 Dr. Lou, DRLOU. Dr. Payne, another busy answer. Any questions outside, again, call that number, get a hold of the clinic, and go see him. And we'll catch you next week right here at 12 o'clock. The Dr. Payne Show on Talk Radio, AM 640.